Hi, my name is Danielle and today I'm going to talk you through the symptoms and etiology, assessment, treatment planning and outcome measurement for specific phobia as diagnosed by the criteria set in the Diagnostic and Statistical Manual, the 5th edition or the DSM-5. Specific phobia will be diagnosed if a client has a clinically significant fear or anxiety when exposed to or anticipates exposure to a feared object or stimulus that persists for at least 6 months and evokes a panic-like fear response in the individual. A diagnosis will only be given if the fear and avoidance create significant stress and impairment. Individuals with specific phobia tend to have sympathetic nervous system responses similar to a panic attack, such as increased heart rate, shortness of breath, lightheadedness, dizziness, feelings of disgust, an overwhelming urge to escape. People with blood injection injury type phobia may also faint due to a rapid drop in blood pressure. Specific phobia can be more than just a fear of the object or situation. Sometimes people fear the physiological symptoms so much they fear they could die, and therefore avoidance is a key feature of specific phobia. People with specific phobia commonly have more than one feared object, and the more feared objects there are, the lower the quality of life. Anxiety and personality disorders are often also comorbid, and this may account for the fact that people with specific phobia are 60% more likely to attempt suicide than people without specific phobia. Often clients report having a fear of the object or situation for some time before it became distressing. Some people experience specific phobia onset as a result of a trauma, either personal or witnessed, and yet others cannot recall a single situation in which their phobia may have been triggered. The age of onset seems to differ depending on phobia type, ranging from mid-childhood for animal and blood injection injury type to early adolescence and early adulthood for natural and situational or other types of phobias. There are 5 goals of a comprehensive assessment. Thorough assessment allows the clinician to identify the specifics of the phobia, any comorbid disorders, and work with the client to tailor a specific treatment plan that utilises the best evidence-based treatment for their condition in their situation. Ultimately, the information gathered during the assessment process will guide the individual client treatment planning and outcome evaluation. A multimodal approach is recommended, including self-report measures, semi-structured, structured or unstructured interviews and behavioural assessments. However, it's very important to understand that this initial interview can be a traumatic process that the client may wish to avoid. That may account for the fact that only 12 to 30% of people with specific phobia seek help. Therefore, it's very important to find out if having this conversation is likely to produce anxiety in the client, and if so, to do 3 things. Explain that these fear responses are normal fight or flight responses, but that they are excessive compared to the harm that is actually posed by the object or situation. Also, the clinician should explain the reinforcing nature of the avoidance strategies and the importance of exposure to the feared object or stimuli. They should also reassure them that despite the distressing level of fear that they are experiencing, that this is actually one of the easiest disorders to treat. This will go a long way to developing rapport and instilling hope in the client, and the value of hope should never be underestimated. Although they're subject to self-reporting error, self-report measures prior to the interview can help to guide the clinician during the interview. Most of them take under 10 minutes to complete. In the clinical interview, the 2 most commonly used semi-structured diagnostic interviews are the Anxiety Disorders Interview Schedule for the DSM-4 or the ADIS-4, the current or lifetime version of which can take between 2 to 4 hours to complete, but includes dimensional ratings of fear and avoidance for 17 objects or situations from the 5 specific phobia categories in the DSM-5 with good to excellent reliability, and also provides DSM-4 diagnoses for comorbid personality and anxiety disorders. The second is the structured clinical interview for the DSM Axis 1 disorders or SCID-4, which can take between 1 to 3 hours to administer provides detailed assessment of a broader range of disorders such as eating disorders or psychotic disorders, but less information on the anxiety disorders that tend to have overlapping characteristics with specific phobia. When time is limited, unstructured interviews may be considered if the following questions are answered. Brief or semi-structured interviews such as the primary care evaluation of mental disorders or the PRIME-MD or the mini international neuropsychiatric interview do not provide as much detail in assessing DSM criteria for specific phobia, and structured interviews such as the diagnostic interview schedule 4 have been shown to overdiagnose a number of disorders in comparison to the SCID and the ADIS. So where time permits, the ADIS 4 is preferable. And finally, behavioural assessment identifies fear cues and intensity with either a selective or a progressive behavioural approach test, or BAT. It's important to understand the focus of anxiety and reasons for avoidance, including the cognitions, beliefs or predictions that the individual is having, also the context in which the fear occurs and the situations or the range of situations that are avoided. For specific phobia, the fear is often anticipated harm. A person who fears flying may not only be concerned about the plane crashing, they may also be concerned about the physiological effects, for example, the sympathetic nervous responses, or the emotional fear, for example, losing control or panicking. They may believe that if they cannot control these physiological symptoms, that they could die. This differs from social phobia because the fear is not related to negative social evaluation. The context in which the fear occurs and therefore the situations that are avoided are related. So for example, a person who fears flying may not just be afraid of sitting on an airplane. They may also be afraid of seeing pictures of planes in books or magazines, or being near toy planes, or hearing airplanes are entering airports, and therefore they may avoid watching TV shows or reading books in which they may see images of planes. They may avoid the most efficient route to work because it takes them past an airport. They may avoid living under a flight path. They may avoid even taking a job opportunity that requires air travel. This differs from panic disorder because the panic attack is cued and expected and doesn't occur in unexpected places or situations. This kind of information gathering allows the clinician to make a differential diagnosis, which also requires a thorough knowledge of other disorders which may have similar or overlapping features. Treatment should also be customised to fit the client's needs and preferences using the information gathered during the assessment. It's always important to consider the client's current situation, their life history, previous treatments, what's worked for them, what hasn't, their relationships, their social network, their work, their recreation and their general health. The clinician uses this information to assign treatment priority where more than one specific phobia is present or where there are other comorbid disorders. Exposure therapy is empirically supported for most types of specific phobia and should focus on the avoidance behaviours revealed during assessment. Ideally, client and clinician should work together to develop a fear and avoidance hierarchy and a selective or progressive BAT. This collaboration can help to strengthen the rapport and the trust between the client and the clinician and form the basis of the best evidence-based treatment for specific phobia, which is in vivo exposure. Some studies show that a single session of in vivo exposure is equivalent to 5 sessions of imaginal exposure. A gradual lead up from low fear-provoking situations to extreme fear-provoking situations over around 5 sessions with a trusted clinician is extremely effective at reducing the levels of fear to a more manageable level. In situations where in vivo treatment may be harmful to self or others, for example a bus driver who's developed a driving phobia, virtual reality may be preferred. So it's also cheap and can be easily administered in the clinician's office. In addition, for clients with a history of fainting, applied muscle tensing, which increases blood pressure, is empirically proven to prevent fainting. Assessment will also help to determine which cognitive strategies to apply to fear-related beliefs, cognitions and predictions. Challenging beliefs and cognitions with CBT may be more helpful for emetophobia and choking phobia with a gradual exposure to fear-inducing foods or situations, but this will require a very trusting relationship between the client and the clinician.
D-cyclocerin has shown promising results in animal trials in improving learning consolidation between exposure sessions and may be a pharmacological aid in the future. In order to measure treatment outcomes, the same self-report measures used for pre-treatment assessment can be used post-treatment. And finally, either a generic standardized measure such as the Client Questionnaire 8 or a more customized clinician-constructed questionnaire that measures client satisfaction with treatment setting and perceptions of quality of care can be administered. Monitoring treatment during treatment is also extremely important. Fear and avoidance ratings from the fear hierarchy can be completed at the beginning of each session to monitor progress and assign homework. This takes a couple of minutes at most and allows the client to see their own progress and reinforces their sense of hope and self-efficacy. Clients who have lived with sometimes socially isolating and debilitating fear will often be amazed and astonished at their own bravery when they realize the benefits of sitting through the anxiety arc and feeling their anxiety decrease when they face their fears step by step instead of reinforcing them by avoiding them.
Thanks very much for watching today. I hope you found it helpful.